So I'm actually recording on a different thing, so I'll post it on YouTube for you guys. But let's start by going over Module 4. So that is Chapter 56. It's page 1419 to 1434. So if you have your books out, if you can turn to there, and we'll kind of talk our way through that chapter. Get there. So a lot of the things, what you really want to make sure that you're looking at with this chapter basically is the types of injuries that can occur with these types of spinal cord injuries. So, what could you see based on the level that you see the injury occur at, and what complications might you see by those areas? So, good thing to look at when you look at the different types of spinal cord injuries. On page 1422, it has, basically what's going to happen in the level of paralysis. It's figure 60-3. And then on the next page, the level of injury with the rehabilitation potential on page 1423 is also really important. When you start looking at these, it's, what can happen with these patients. So, with your spinal cord injuries, what's the level, what is the treatment, what kind of diagnostic studies are we going to use? So what type of diagnostic study would you expect to have if you have a patient that comes in with a spinal cord injury? You might see an x-ray, but the x-ray is not going to give you the actual spinal cord. The CT scan, yep, the CT or the MRI, but usually they're going to do a CT scan first. If you have a patient that you suspect might have a spinal cord injury, what's the first thing you do for that patient? What's your priority nursing intervention? Yeah, I love that that's all caps. Stabilize the spine, absolutely. First thing you do is stabilize the spine. Once you stabilize the spine, then you're going to focus on the respiratory system. Why would you not automatically go to airway if you have a patient with a spinal cord injury? What's the rationale for that? Yeah, you can have further damage. Why? If you think about it this way, if you have somebody who has a spinal cord injury of their neck, and you go and you move their head in any direction, you can actually sever the spinal cord. What's going to happen if you sever their spinal cord? They're going to die, or they're going to have worse, issue. But if you have a high level, especially if you have a cervical spine injury, it can cause a lot of issues and problems in that particular area. So you can give them all the oxygen and all the CPR you want, but if you get them back, you're not going to get them back if you sever their spinal cord. So stabilize. Does that mean run and get a C-collar? Would you try to go and get a C-collar before you start doing anything? What do you think? When I say stabilize the spine, a lot of you are probably automatically thinking, so how can you stabilize the spine without a C-collar? No, you don't need to run. You don't need to rush and go get a collar. And most likely, if you're coming up on someone, you may not have one. You can have someone grab one if you have the extra hands. But basically, you can have someone hold the neck in alignment. You can put stuff if you're by yourself. You can find something to put there to hold the neck in alignment. But basically, you want to just make sure that the spine, is, especially if it's a high spinal cord injury, but you want to just make sure that you're not moving them in a way that's going to potentially cause damage. So yes, look at the alignment and keep it aligned. I've seen where you can put like a purse, different things, a backpack, when you have someone with a potential. You can have someone else, if you have an extra set of hands, hold it without moving. So it just depends on, what you do. But stabilizing the spine doesn't necessarily mean going and get a C-collar. So again, make sure you're looking at that. Make sure that you're paying close attention to what can happen at that level. One of the big misconceptions, did you guys see in the, I'm not sure if they showed it in the spinal cord injury synchronous session, did they show you the thing with the roller derby? Or did anybody see that? I can't remember if it was in there. I didn't look at the one this semester. So there's actually, they have like wheelchair rugby. Has anyone ever heard of that? Okay, so they actually have wheelchair rugby, and if you have a chance to go on, I'm looking to see if I can find the name of it again. I thought it was in the session, but it's a lot of people. Then they actually are in wheelchairs, but the common misconception is if someone can use their arms, does that mean that they're automatically a paraplegic? No. Most of the people that are in this are actually quadriplegic patients. They can still use their hands, but the level of the injury, and they have some dysfunction, but the level of the injury is really what determines that. And while they may not have full control of some aspects of like their chest or their shoulders, many times they still have they do have the function. So that's a common just looking for it now. That's a common misconception. So yeah, if you go online, there's tons of them that are coming up. They call it murder ball. That's what I was trying to find. So if you Google murder ball and you really look at the stories, I mean, it's dangerous, but it's really, really interesting when you watch that to know that a lot of the people that are doing that are actually quadriplegic, not paraplegic. So just figured sometimes it's like a realization that people see. I learned that when I was in a class, someone showed the video, and I automatically assumed that, when I was in nursing school. So it's neat. So take a look at it. And then complications with spinal cord injury. So what would be the complication, and what would be your priority intervention if you saw that complication occur? So when you're looking through here, you see all the different things that can happen with their integumentary system. So, what are some risk factors with spinal cord injury for integumentary? Skin breakdown. So what would be your priority nursing intervention? Yep, turning and repositioning. Cardiovascular system, a lot of times you can have cardiovascular impacts, and they can end up going into neurogenic shock. So you want to watch for that, assess for that. They can end up with hypovolemia, so another really big thing with that. The urinary system is a big one that you want to make sure you're paying attention to with any time you have a patient with spinal cord injury. Neurogenic bladder is a big, big, big one. So it's, a lot of times they're going to need to be catheterized. Sometimes it comes back. I will tell you, I actually had a spinal cord injury in 2008. I was in a car accident, and I fractured C5-6, and I had a spinal cord compression. And one of the ways I realized it was I thought I might have had like neurogenic bladder from a seatbelt. Right after the accident, I was like, oh my gosh, I peed my pants. What the heck is going on? I thought, how weird is that? It was probably just from the impact. I totally ignored it. I was a nurse. I was teaching nursing. I was meeting my students. It was their last day of the semester, and we always did like a big dinner. I was right in front of the restaurant, and I got T-boned. I was in the median with my blinker on to turn into the restaurant. They were all out there. They saw the accident. They helped. Husbands, everyone came. It was kind of crazy, but of course I'm like, all right, I'm going to tie my sweatshirt on my waist, and I'm going to go, and I'm going to say goodbye to the students, and I'm going to be okay. And slowly the shock was starting to hit, but the pain started. So I ended up in the hospital. And long and the short, the person at the scene and EMS at the scene, I never had neck pain. Never, ever had neck pain. My hand hurt, and my whole side was bruised. They hit my door, but nobody ever stabilized my spine. So just because a person doesn't have neck pain, you don't ever want to assume that they don't have a spinal cord injury. I ended up having surgery, going through the whole gamut of that. But at the scene, nobody ever stabilized my spine because I climbed out of the car on the opposite side myself. And I said, nope, my neck's fine. Totally fine. Doesn't hurt. Just remember, when someone has those injuries, a lot of times they are in shock. And if I had told them, yeah, I peed my pants, they probably would have been like, she could have a spinal cord injury, but I didn't. So that's something that there's those weird things that you want to ask. Anything weird happen? Did you have any bowel or bladder incontinence? Things like that when you have someone that could have a potential spinal cord injury, because I had the neurogenic bladder as a result for several months. It obviously eventually, function came back, but that even though it was a high level injury, it caused damage to other nerves. So you want to always pay attention to that. And teaching the patients about it. So what can happen, how you handle it, what you do. Thermoregulation is another one that's really important with these types of injuries. So paying close attention to it. And then obviously pain is another one. With patients with any of these, types of injuries, it's always assessing, and going, thinking about what is the history, what was the injury. It talks about the CT scan, the MRI. And then an EMG study is something that they also do. I had one of those. Has anyone ever heard of an EMG study? It talks about it on 1426. Anybody heard of an EMG study? No. So an EMG study is they actually take needles and they put them in your wherever the area is that they think there may be a nerve dysfunction. So for me, mine being my neck, I had lost sensation in my entire shoulder and arm. I had no function in my hand. I was in a sling for, I think, 3 months. It was 9-month recovery. And the EMG study, they actually put needles, like they're very, very thin, almost like a acupuncture needle. They put them from my neck all the way down my arm into my hand. I think they put in like 50 needles. And they actually send nerve impulses and they wait to see, they're measuring how the nerve and the muscle reaction happens when they do the impulse from one area to the other. And they measure how fast the electrical conduction happens from one nerve to the other. And that's the way they know whether the nerve is severed or whether it's just irritated. So that's how they knew, they could kind of gauge whether, the nerve was impinged before they did the surgery. They can tell if, like I said, if it's severed, and usually the degree to damage that's done to it. So that's called an EMG study. So if you haven't seen it, try to Google it. It's something to watch the video. It's interesting to see. Everyone told me it was like the most painful, horrific thing in the world. It really wasn't bad. It was awkward, but it wasn't as painful as I anticipated by any means. So if you ever have someone that has it, you'll hear that, but it's really not that bad. But so those are the diagnostic studies that you really look for that. What are some other things? So looking at that table 60-4 for your cervical cord injuries, what are some other things that are really important to include in the plan of care for these patients? Page 1426. Anybody? Yes. So you want to prevent thrombosis, VTE, absolutely. So what would you? Yes, and stress ulcers, another big one. So what are some meds that you think you'd see the patient on? PPIs, yep. A lot of times Lovenox, yep. Heparin or Lovenox, whichever, either one. So in the hospital, I was on Lovenox. I was also on a proton pump inhibitor prophylactically until I got discharged. Once they discharge you, they usually take you off. And then basically just, turning repositioning, bowel and bladder retraining is a really big thing, and it's a sensitive thing. I remember having to I coached basketball, and I wanted to get back to coaching basketball so bad, but I was like, I am not sure that I can be out on the court for an hour without, not even realizing that I'm going to have to go to the bathroom. So it was a really weird thing. I was like in my 20s at the time. So it was a very awkward, uncomfortable situation. But teaching them and teaching people, you have to go certain times. So I would have to basically set a timer and remember to try to go to the bathroom at certain times to get my bladder functioning again. And it took about 6 months before I was completely back to normal. So it's a stressful thing. Physical therapy and occupational therapy too. So it's getting them range of motion, and that's something that you'll work on interprofessional care with. Occupational therapy, a lot of times it's just the simple tasks. I had to learn to be able to pick things up, and I still have very altered fine motor skills. It drove me crazy. They used to put a box. Has anyone ever been to or seen occupational therapy? So they used to do what they'll do. They would have this thing of beans, and then I gradually they would do rice, and they would put little objects, and you'd have to basically sift through and pick out the objects from the rice, and then they'd stick them all back in and make you do it again. And I used to get so frustrated. I'll never forget it. But it's basically learning how to do things that you normally could do, and it's your mind and your function. You have to be able to reteach yourself. So that's a big part of that rehabilitation and home care. So they'll start it in the hospital, and they'll progress it when they get out of the hospital. Primary, your priority nursing diagnoses, obviously on page 1426 are important. So thinking about in that application and analysis level is where's the level of injury and what would your priority nursing diagnosis be for that particular area. So that's in the nursing management area on 1426 to 1427. And then, gathering information. Again, it's the assessment. No one ever assessed. Even in the emergency room, nobody ever put anything on my neck. Nobody ever stabilized my neck, and they didn't do an MRI or a CT scan. I went back 2 days after my car accident because I was still incontinent, and I'm like, okay, why am I peeing my pants? And I thought I had like neurogenic bladder from the seat. You can have like a seatbelt injury, and I just thought that's what it was, because I was a nurse, and I'm like, I know my body, it's definitely that. They ordered a CT scan outpatient, and next thing I know, I'm getting called into the doctor's office and in a C-collar finally. But in the course of that whole process, no one ever really asked. And if you look at it and you look at these things, those are key things that you need to ask the patient about. When would you be concerned if you have a patient with a C1 to C3 injury? If you start to notice a change in the respiratory rate, so maybe they're okay at the beginning, but you're going to be going to have ongoing assessments. If you notice that person is maybe struggling a little bit, or the respiratory rate has decreased, or it's gotten more shallow, obviously you're going to be really cognizant of that and paying close attention if they have an injury that's at that level. So it's really kind of getting a feel for what the biggest issues are by the level that the patient has the injury. It talks about the acute care. Again, I can't stress enough, the first thing you do is always stabilize the spine. And then it talks in here too about your halo. Important to make sure you understand what the halo vest is, the care for the halo vest on page 1428, table 60-6. What are you going to do? What are you not going to do? And what are you going to teach your patients and family members? So what can they do? What can they not do? Absolutely, you need to know that. And then basically any type of dysfunction that can happen. So it talks even more about respiratory dysfunction and what you're going to do. How are you going to assess for it? When you start to see these things in here multiple times, you know that it's really important. Making sure that you're looking at their fluid and nutritional intake. Make sure that you're, that they have adequate nutrition. And obviously, again, it goes back into your bowel and bladder, your stress ulcers, all that stuff from 1430 to 1431. A big thing to make sure you understand is autonomic dysreflexia. That's on page 1431. What is autonomic dysreflexia? Tell me a little bit about it. It can be from a distended bladder. What else can cause it? Yep, a kink if they have that. So anytime you have a patient and they have, so what would be the signs and symptoms that you're going to see with this? Hypertension, headache. They're really, really diaphoretic above the level of the injury. That's a really key thing. If you know the level of their injury, it's that diaphoresis that occurs there. Yep, they're going to get the goosebumps, the nasal congestion. So it's almost like flu-like symptoms. And that's what a lot of times they'll say, I feel like really sick all of a sudden. I feel like I have the flu. Check their vital signs. But then what would be your priority nursing intervention if you have a person who you suspect has autonomic dysreflexia? Yep, sit them up. Why are you going to sit them up? Yep, so you're going to assess. All right, I see that. Sorry, Carlene, you got it. You're going to assess what the cause is. So what are things, so we already said that a full bladder, distended bladder, it can be that they're constipated or they're impacted. It could be stimulation, even something as much as clothing that's too tight. So figure out what's causing. Are there socks? And you just really quickly look. You don't have a lot of time, so the first thing you're going to do is try to figure it out. Why would I not call the doctor and say I think the patient's got autonomic dysreflexia? Why would that not be the first thing I do? It can worsen. Yep. What's the doctor going to ask you? Yeah. You need an immediate intervention and assessment. And the doctor is going to ask you, okay, what do you think the cause is? Did you check the bladder? Did you check the, are they impacted? Have they had a bowel movement? When was the last time they urinated? Is their clothing too tight? It could be underwear. It could be pants. It could be socks. It could be anything that's causing it. It could be their position. It could be that the linens are bunched up underneath them. So you need to really just assess the cause and figure out why is this happening and what can I do to alleviate it. Then you'll see the patient improve. If you can't figure it out, you've done all those things and the patient's still getting worse, obviously then you're going to call for help. So make sure you look at that. Making sure the pin care and care, I said that with the halo vest, make sure you understand that. And then with getting into your patients with spinal or increased cranial pressure, chapter 56. What are signs and symptoms of increased intracranial pressure? Pupils and level of consciousness are two big ones. Yep, absolutely. So making sure you're understanding all of the signs and symptoms of increased intracranial pressure. The other thing, phases of the spinal cord injury are on 14. Hold on, let me go back to it. I just went past it. So really what I'm looking at with that is more so understanding your, your pre-hospital or acute management, in-hospital management, and then home care rehabilitation. So understanding, what are you going to do if it's like the initial phase or the onset. So your emergency management that's on page like 1425 versus your interprofessional and in-hospital care, and then your rehabilitation stuff after. Yep, so sorry. So now, Carlene, yep, you're going for the increased intracranial pressure. Yep, you're going to see motor changes, headache, unexpected vomiting, all that are signs and symptoms. And then basically look at how are you gonna treat it? What are you going to do for your patient? What would be contraindicated? Your positioning, your interventions, and all that for increased intracranial pressure. So what would be some things that you would expect to use for treatment of increased ICP? Why mannitol? Why not another type of diuretic? Yep, you could use that. Why not Lasix? Why mannitol? It's the only one that's going to cross the blood-brain barrier. It's the only diuretic. And how about positioning? How are you going to position the patient? Yeah, I see it now. Currently got it 30 to 45 degrees. Sorry, I'm trying to catch up on your comments here. Another one that's important is page 1318. Make sure you're looking at figure 56-5 and understanding the decurbit and decorticate posturing. So what it is, what does it mean? When would you be concerned? So take a look. Those are the two that you really need to make sure you know. Let's see, where are we? Priority management. Who would you see first? So when you're looking at these patients, like what would be an indication when you're looking at prioritization of care that you need to see the patient before someone else? Not necessarily just someone that's drowsy. What else? What is Cushing's? Good one. What is Cushing's? What else? Widening pulse pressure. What else? Bradycardia. It's an increased systolic with the widening of the two and irregular respiratory rate. Yep. So making sure that you're looking at those. Basically, it's going to be your patient who has not already had an intervention. So when you're looking at something, if they've been assessed and they've had an intervention, then they're not going to be your priority. If you have someone that's really, really sick, it's morbid, and we'll talk about it again in Module 8. If the patient, always going to look at it and say, if I didn't see them, who would die first? That's an awful thing to think about, but you really want to look at who's the most severe, who hasn't been assessed or who hasn't had interventions. So you kind of want to prioritize it that way. But who's the worst? So that would be your priority, in triaging. Meningitis, make sure you're looking at your signs and symptoms, interventions and treatment. What type of precautions would they be on? What would be risk factors? What types of patients are at high risk for getting meningitis? And then what could you delegate for treatment? Glasgow Coma Scale. What is important about that? That's on page 1323. Well, someone that's got decorticate or disturbed posturing, what would be the care for them? It really depends on what the cause is. When you see it, you know that there's brain injury happening and potentially brain death. So it's figuring out what the cause is and treating the patient. The posturing is a sign or symptom that something else is going on. So it's not really a condition, more so it's a sign or symptom. You're welcome. So with GCS, what's the best score that you can get for the Glasgow Coma Scale? Yep, 15. So if we have to know, yeah, it's anything that can cause ICP. So anything that could potentially cause it. It can be injury, it could be abscess, it could be tumors, it's any of those things. Yep. So when you're looking at the Glasgow Coma Scale, what would you be concerned about? A decrease in the number, right? So anytime you have a decrease in number, what you want to also think about is if you have a number and then you have multiple things that have happened that could drop the number lower, then you would also be concerned. So knowing what the worst possible things are. So if they have spontaneous response, that's a lot better than if they have completely, it's untestable. They're not opening their eyes, they're not responding to painful stimuli, they're not responding to anything. So the more of the negative areas, then obviously the worse it is. And if they've had a change from a high to a lower number, you want to be very cautious. CSF and head trauma. So making sure you understand the different types of head trauma. What are the manifestations? What would you see? That's page 1327. Some of the signs and symptoms. And then your dextrostrip test versus your halo test. Why would I use a dextrostrip test versus a halo? What's the difference between the two? They both test for what? You're saying glucose, yep. But what are they testing? They're testing to see if it's cerebrospinal fluid, right? And they are looking for glucose. Why would I use the halo test over the dextrose when blood's present? Why? It's not the color. Blood has glucose in it, so it's going to be a false positive, or it's always going to be positive if there's blood in it. It may be positive because it may be cerebrospinal fluid, but it may just be clear drainage with blood. So the halo test is the only one that you would use if there was blood present in the fluid. And then traumatic brain injury, signs and symptoms, interventions, and the priorities that you would do. This chapter has you're looking at different types of head injuries, your coup, contra coup, the hematomas, understanding what you're going to need, how you would diagnose it in your interprofessional care if you have a patient that has that. The other thing, at the end of this one, it has a really good thing on traumatic brain injuries. You're not going to need to know the different types of tumors, but make sure you understand what the cranial surgery, what it is. Actually, no, it's not part of your reading. Never mind. Just ignore me. Traumatic brain injury, page 1432. There's a really good case study here about the guy that came back from deployment. Make sure you take a look at that. It's a really, really good one. And then understanding what cerebral perfusion pressures are and what that would mean. Module 5, your shock mods and sepsis. Delegation for meningitis it's not really listed anywhere. It's think about things that you could do. So if you have a patient with what can a UAP do? What can an LPN do? So you think about the care that you're providing for the patient, and then think about what in that care or what priorities you would say, okay, this is what an LPN can do and this is what a UAP can do. So just kind of think about it as you go through. It's not really listed out anywhere in any of the chapters, but you'll see a lot of those types of questions when you get to your board. So I'm trying to put them in here for you too. So let's look at chapter 66, patients with shock. So make sure you know the types of shock. So be able to differentiate between them. A really big thing with these is basically looking at, so when you look at page 1591, you do not need to know obstructive shock. We don't test on that, but the others are all tested. When you look at them, what do you think, if I'm looking at table 66-3 on page 1591, what would be the best way of approaching this to make sure you understand it? What do you think? You're going to try to memorize every single direction of every single arrow? The difference is, yeah. When you look at this, you want to almost say, okay, almost all of these, if I looked at the renal system, have decreased urine output, except for anaphylactic, which could have incontinence, and neurogenic, which could have bladder dysfunction, which if you think about a neurologic deficit, that kind of makes sense, right? Another thing, is looking at, your vital signs with them is look and see which ones are different. Most of them follow the norm, but some of them are different. So most of them here are going to have tachycardia, except neurogenic shock, which is what? Bradycardia, yeah. So kind of understanding the differences with them is what you want to really look at. That's a really good thing to make sure you're kind of understanding the variations. What's the big thing with cardiogenic shock that's different than the other types of shock? What about fluids? You want them slow. Why? What's going to happen if you give them too fast? It can lead to heart failure. Absolutely. It's going to add stress on the heart, and you're going to end up sending them into heart failure. So yeah, you want to be very, very cautious with that one. And then also make sure that you understand the different phases of shock too. So take a look at that and make sure you understand the compensatory, progressive, and refractory stage of shock. It's really what's happening in the systems as you go through. Practice questions are really, really good for these. There's a lot of them right in the synchronous session that I would just really make sure that you're looking at, and it'll help you to kind of understand the differences. What would be your priorities with these patients? So when you have a patient that comes in with shock, what do you want to do first? What would be your priority? So fluids is one for almost all of them, right? Get the IV in, get a large bore, at least one large bore IV. What if you can't get an IV? What are you going to do? Yep, IO. IO is a lot faster, and then usually we'll prepare them for central line, but you can do an intraosseous. Yep, making sure they have oxygen is another important thing. But getting that IV in and getting your fluid started, unless it's what? There's two of them that you got to do something else. So if it's cardiogenic, and then what about neurogenic? You're going to stabilize the spine if they're not stabilized, or if it's an acute injury. But there's another one. What about anaphylactic? What do you think your priority for anaphylactic is? Epi. Airway and epi. Absolutely. So it's really thinking about what's happening with this patient and what do I need to make sure that I'm doing to handle it. Knowing the treatments, the medications for the different types is also extremely important. So what are you going to do? What are you not going to do? Most of them you're going to give the, your isotonic solutions. People always get hung up with burns and with this on, should it be lactated ringer? Should it be normal saline? They're both isotonic. It really doesn't matter. Usually you're going to see normal saline given for sepsis and for shock, but you can also see the other. Sometimes they'll give fluids, but you want to be very cautious with giving fluids for cardiogenic shock. If they do give fluids, they're going to give them very, very slowly, and they're also going to usually be putting them on what? They're going to be on ECG monitoring. Yes, they're on tele. they're going to usually have them on medication. So they might have them on like a sometimes they'll give them diuretics if it's a failure type thing or if it's a fluid overload. But remember, there's a lot of things that can cause cardiogenic shock. If it's myocardial infarction, if it's, cardiomyopathy, if it's, I'm trying to think of all the things I've seen, pericarditis. I've seen people go into cardiogenic shock with pericarditis or endocarditis. So it's figuring out what the cause, they're going to treat the cause, but to sustain the heart, the cardiac output is really what you're focused on. So you might have them on an inotrope, different drugs. So, it talks about those on page 1599 in table 66-8. So it's really whatever the reason is that they're going into it is what they're going to use. If somebody's has too much fluid and they had heart failure and that threw them into cardiogenic shock, you're definitely not going to give fluids. But most of the types of shock you will. So cardiogenic, you just want to be very, very, very cautious with that. We already talked about oxygen. And then knowing how are you going to know if you have a patient with hypovolemic shock and you give them fluids, how do you know that it's effective? How are you going to know that it's working? Yep, why urine output. Perfusion of the kidneys, yep. What is that an indication of? Adequate cardiac output, right? If our cardiac output's not good, our kidneys aren't going to be perfused and we're going to have no urine. So what would be an adequate amount of urine to see? At least 30 mLs an hour, right? And then going back to the basics, what is the pathophysiology of shock? Make sure you know what that is, what happens with shock, what causes shock. So just really understanding that. And then SIRS, MODS, and sepsis. So, understanding on page, sorry, I'm looking for the one for the guidelines. If anyone gets to it before me, what is the page number for sepsis? I'm looking at SIRS is, it's in a weird spot, 1592. It's such a weird spot to have it, but for sepsis, because sepsis and SIRS kind of go hand in hand. Sepsis, high or low is important. Yep. So I see someone said with sepsis, can you explain white blood cell count? So when you look here, with sepsis, you can have a high or you can have a low white blood cell count. So my husband ended up with a mesh infection, a few years back, and he ended up with, he had sepsis 4 times before they finally took the mesh out, or 3 times and once after. And every time he would go in, it would be different. Sometimes he'd have a high fever. Sometimes he'd be very like a low temperature. He'd be like 95 degrees Fahrenheit a couple times when he would come in. He was always really tacky, and a lot of times his O2 sat, almost every single time his sats were low. But the one thing too, that the first time he had it, they missed it. And I kept saying, he has an infection. He had dehyst after surgery. And he had, it's so weird. We have these 2 stories for this particular chapter, but so the first time he went in, his white count was like 2,000, and his temperature was like 95, and they missed the criteria for sepsis. And I kept saying, I'm telling you, I think he's septic. And I finally got them to draw a lactate level. What is a lactate level going to tell you? What does that tell you? Yep, the anaerobic metabolism is happening. So one of the ways that we always knew that he was getting septic is he would get pain in his legs. And that's, when you get that muscle pain, that's a sign of sepsis. That's a sign of anaerobic metabolism occurring. So he would always get that pain in his legs, and that was usually our first indication that we need to go back. We needed to get him to the hospital, or that we would need to kind of figure something out. We'd go to the doctor sometimes and catch it early. Usually it wasn't actually septic yet, but it was when he was starting to get sick. So you can have a high or a low white blood cell count and a high or a low fever. Either one of them are indicative of and variables that are in the diagnostic criteria for sepsis. The one thing that you'll see now in most hospitals is when you put in the vital signs and you put in the labs, or the labs are put in, most of them have I'm totally lost for the word for it, but They have within the systems, it actually will automatically catch those things, and it'll flag you that the patient needs to have sepsis screening. But that first time when the doctor finally came in to see him, I said, listen, he's been sick. He's been sick for, at that point it had been like 6 or 7 months post his first surgery. He just had his second surgery. Now he dehyssed. I'm like, I want a lactate level. It came back at 8. So he was septic. That was his first hospitalization, but it varied every single time. It was never the same. Sometimes he'd have a high fever. Sometimes he'd have a low fever. So it was really interesting to see. And then the other thing is the hyperglycemia that can happen with the absence of diabetes. And that was one of the other things when he got really sick. One of the times his blood sugar was really high. No, there's not a normal lactate level. What is the lactate level going to be? Your book actually says greater than 1, but most hospitals, when you get into the hospitals, I wouldn't test you outside of the book, but most hospitals are going to tell you it's great that 2 to 3 indicates that there's some kind of inflammatory infectious type process, and over 3 is diagnostic for sepsis. But these are the variations and things you can see with sepsis. But it's really important. They're going to get ABGs. They check to see what's going on, and all these other things can happen. So it's really important. But that lactate level is going to be one of your big diagnostic criteria in addition to all of these other things. So make sure you know that table. Very important with sepsis. And then MODS. So how do I know that the patient has progressed to MODS? How would I know? 2 or more organ systems fail. Yep. What would I be assessing for to determine that? Lungs would be a good one, but we can't really, the only way we would know lungs is if they're, difficulty breathing, they aren't breathing on their own, their sats are dropping, they might have, decreased or lung sounds. But what other ones? BUN and creatinine urine output are going to look at our kidneys. How would I look at my liver? AST, ALT, absolutely. And then looking at the heart, I'd be looking at your BNP. So, what's going on with the heart. So all of those things are going to give you an idea of what's going on with the patient and if they are indeed going into multi-system failure. So moving on to burns, chapter 24. Big things with your burns. Obviously, you do need to know your rule of 9s. Make sure you know the rule of 9s. Make sure you understand if you are given a patient with explanation. So one area of clarification that people always struggle with is when you're looking at the trunk, it would either say anterior or posterior. So you do not need to know the Lund-Browder chart. You do need to know the rule of 9s. Everything goes by like the 9s, the 4.5, 9, 18. They're all the different parts. But if I was looking at the anterior trunk, what would be my, and I'm on page 433, anterior trunk, what would be the percent of burns? Yep, it'd be 18. What if I said the anterior chest? 9. It would be half of the trunk. If I said anterior abdomen, it would also be 9. Make sense? What if I told you that the lower half of the right leg was burned circumferential? Lower half of one leg circumferentially burned. What does that mean? Circumferential means all the way around. So, yep, it's all the way around. So it's the back and the front. So if the whole leg is 9, half the leg, or the whole leg is 18, front and back, right? Remember, we're looking at B. We're looking at the rule of 9 chart on page 433. So it would be 9. It would be half of the one leg. So the whole leg, front and back, is 18. The front is 9. The back is 9. So it would be half. It would be 9. So that's what you want to kind of look at and be able to figure, differentiate those. And then if I were to give you the rule of 9s, you'd also want to apply the Parkland formula. Some areas it talks about the Parkland formula being 2. For testing purposes, it's always going to be 4. So it's 4 mLs times the body surface area burned in the kilograms. So make sure you practice that. So that would be definitely, it is a question because you can see it right there, Parkland formula. So make sure you know that. looking at the phases of the burns with the labs that you would expect to see and why you would expect to see the labs that way for each type. Yeah, always round at the end. Make sure you know the phases of the burns with the labs, assessment, and treatment at each phase of burns. Really good. It's really good and clear right through the chapter what you would need to know for each of them. Understanding the burn injury with interprofessional care is really good. That table 24-10 on page 438 has a lot of really good information in it. The types of burns and what you would do, what you would need to do. So what type of burn would be treated differently? Yep, electrical burns. Why? What's a priority with an electrical burn? Once you've maintained safety of the person responding, you need to stabilize. Why would you stabilize the spine? That's a good one there too. Stabilize the spine first. Why? You're not sure if they've fallen, if they're injured, or what could have happened. When someone has another type of burn, like if they have a thermal or a chemical burn, they're usually responding or doing something. They're falling to the ground and putting it out, or they're like rolling to put it out of their clothes, or they've dropped something or splashed something. These patients, it happens fast, and they could have fractures, they could have fallen, they could have injury. So stabilize the spine, and then go assess. What's the other important aspect with that? Heart. Yep. So what are you going to put them on? Telemetry and get an EKG to make sure that there's no conduction issues with the heart. Absolutely. Another one too is your smoke and inhalation injuries. Is pay close attention to that. So what are you looking for? You're looking at, are they having any difficulties? It talks about that page 431, table 24-3. Yep, myoglobinuria. What is that? Why would we be looking at the urine for a patient with a electrical burn? It's kidneys too, but so basically it's the injury of to the muscle, and they're gonna be basically have red urine. So you're gonna see yes, the muscle damage causes the release of the myoglobin that is then goes through the urine, and it'll be red. So basically it's gonna look like blood. They're gonna be peeing usually red. And you're going to be titrating it and giving them aggressive fluid resuscitation to try to clear that out and keep the kidneys functioning. Back to the lung injury, page 431, table 24-3. That's a really, really, really good chart with a clear, like to the point, here's the things that you could potentially see. So did this totally kill This Is Us for you guys? How many of you guys, I think I mentioned it before, have you guys watched This Is Us? It's table 24-3 on page 431. So how many of you guys were like, Jack would never have been like sitting in a doctor's office on a table like that and not have been intubated, right? Totally killed it for me, that plotline. Still love the show, but if you think about Jack from This Is Us, he had so many of these. It is a great show. But he had so many of these signs and symptoms that anyone in their right mind, doctor, nurse, or elsewhere, any of us know, right? We would have been like, no, he needs to be intubated, right? He had the dyspnea, he had the hoarseness, he had the what do you call it? Carbon in his nares in the show too. So he had so many things here that should have been red flags that he should have been intubated. What happens if someone continues to have this problem? A, their airway could close, and B, they could go into cardiac arrest, which is what happens with him. So it's really important to make sure you're assessing for these things. The other thing with that is the referral to the burn center, which is on page 432. Making sure you understand who would be referred and why. So that's 432 on table 24-4. So it's really, your significant burns. You're usually going to get them stabilized and then transport. The only time, so if burn injury to children, they would go if they don't have the ability to care for them. If they have a pediatric center and it's a very small burn or superficial, then they would still they would be able to stay, in the hospital. But um, if it's a significant burn, then obviously then they would go to the burn center. But that's a good table to make sure that you're looking at. And then the appearance and classifications of the burn, table 24-5 on page 432 is another really good one to make sure you're looking at. Very clear and to the point. Medications for burns is really important. What did you guys learn in your burn sim this week? Tell me about meds in your burn sim. IV, get an IV. Pain medication is really, really important. Yep, usually morphine. Check for sulfa allergies. Absolutely. Why? You can sometimes see those, but Solvadine is a sulfa drug. So if you get that ordered, the silver Solvadine, if the patient has a sulfa allergy, they can have a reaction. Usually it'll start as like a topic, like a localized reaction, and it can end up being systemic where they end up going into like an anaphylaxis. So really, 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 really important. Typically, they're not going to code right away. I think they really threw that in for you guys to get you used to code because you have an interesting one coming up this week, but not necessarily a code, but I mean an interesting sim. But they usually they're not going to code if you put the silver Solvadine on them. They're going to have like a localized reaction. It would be just like giving someone a penicillin, penicillin that's got a penicillin allergy. Usually it'll be like a topical irritation, and then it'll gradually go to like an anaphylactic type thing. So it's not usually right away, but it can cause problems. And if you think about it, if your patient has a burn already, their skin's already at risk, so you want to be very careful. Infused dressings, yep, someone talked about antibiotic, topical creams, all of those are really important, and giving IV pain medication. And I do believe someone just said making sure that you medicate them prior to debriding because it's very, very painful. I had a friend that worked at a burn center. What did you guys read when they go in to do debridement and they go to the OR? What's the temperature like in the OR? Do you know? It's hot. So one of the things that they do, so they keep it warm because these patients have issues with thermoregulation, remember. But she said she actually teaches in the program here at Utica. I don't know if any of you guys had her early on. Probably not. She's in 321, and now she's also doing OB. But anyway, so she was saying she actually did her clinicals at Johns Hopkins. It's Professor Murtaugh. Her last name just went totally out of my head, but Professor Murtaugh. So she said when she did her, she went to Johns Hopkins for nursing school, and when they went to the burn center, she said they would rotate in and out of the OR like every 15 minutes because you would be drenched because it was a sterile technique. So they had gown, gloves, everything in the OR, but that they would be dripping with sweat. So they'd have to just constantly rotate the nurses in and out of the OR. And I believe the doctors, I don't remember what she said with the doctors, but you just get so hot in there that you'd have to rotate. So that was really interesting. And then basically your nutritional needs. So what is your priority nutritional supplementation for a patient with burns? And you don't worry about, you're not going to, the warm temperature, it's a sterile environment, so it's not going to really have much effect on bacterial growth. The bigger issue is the patient can't they can't maintain their temperature, the thermoregulation, so it has to be warm. So enteral, so orally is priority. Why would we want to get them, eating and drinking soon? Yep, you can extra supplements, high calorie, high protein. The reason you do that is you want to get the intestines moving, right? They have the increased metabolic demands, but we also want to get the stomach moving again, because what's one of those complications that we try to prevent by getting them enteral nutrition soon? Paralytic ileus is one of them, but there's a specific thing that can happen. We put them on PPIs to prevent it. Stress ulcers, what's the name of it? Curling. Yeah, you got it. So the curling ulcer is specific to burn patients. I think we talked about it in another area, but we'll get them on proton pump inhibitors to prevent the curling ulcer, which is specific to burn patients. So you really want to make sure that PPIs is one of those meds that's in there too, and get the enteral nutrition going, as quick as possible. And then make sure you're looking at the grafting. H2 blockers sometimes, but normally a lot of times you'll see them just on like a PPI. Really depends. I mean, it depends on the patient, what's going on, how long they've been without any enteral feeding. And then the types of grafts. So understanding what the different types of grafts are. I'm trying to find the page. Page 440, table 24-12 has the different types of grafts. So, people always say, oh my gosh, they always take these questions out of the tables. If it's in a table, it's also in the reading. So I always bring you back to the table, but also when I tell you there's a table, look and see where it talks about the table in the reading because there's more information in there. But if it's in a table, it's important because it's also discussed in length in the book too. So when I'm giving you these tables, always make sure you're going back and looking in the reading and reviewing that information too. But it's really understanding what's a permanent type and what's a temporary. So you'll see a lot of times that they want to keep the burns covered. So you might see them doing a temporary as the wound is healing because then they're going to be debriding it. They might be regrafting it. But ultimately, a lot of times what they're going to try to do is an autograft. Why would they do autograft versus an allograft? It's from the patient. So what's less likely to happen? Rejection. Yep. So we try to take it from the patient. If they have too much burn, sometimes you can't. And that's where you would see the other types that are listed below that are the permanent. But really, it's understanding the best case is usually to try to do the autograft. And then the drug therapy that we talked about is on page 441, all the different types of things for treatment. And then complications are the other big thing. So understanding some of the big things that people really get confused about is what do we start at what phase of burn. So understanding what are the nursing actions, and know that some of them you'll start right at that initial phase and you'll be using them, you'll be implementing them across, like rehabilitation. We're starting that right away because we don't want that skin to tighten up. We don't want complications. So it's understanding the different phases and what you're doing. The emotional aspect of burns is also super important to make sure you're paying attention to. And then, again, any of the complications and what you would do, what would be your priority interventions as a nurse to prevent the complications. So that is it in a nutshell. Your math, this is exactly the types of math that you're going to have. There's 2 titrations. There's a critical care titration. There's 2 based on weight, 1 critical care, a heparin drip, and then restarting the pump. And then, again, the Parkland that goes along with the burns. So if you have any questions, reach out to us. But it's pretty much straight to the point. I think between all the sessions and the review and stuff, I think you guys are in good hands. I also think that your quiz questions and the prep sheet should really, really help you guys from lab. We've worked closely with the lab faculty to make sure that you guys have what you need, and that hopefully by doing the sims and stuff, you're going to understand this and be able to apply this stuff a lot better. So I think you guys are going to do good. I hope that you are confident in that too, and please make sure you reach out. Yeah, there's a heparin drip question, and then there's also one that's restarting. Yeah, that's in the math. So it's restarting the pump. Like if you were to stop the pump and need to reinfuse it in an hour, how long would you set the pump for? Those types of questions. All right. Take care, guys. Have a great rest of your weekend. You're very welcome. You're welcome.